anyways.
Correct,
We plugged
and
them
that
in, but we just didn't have it on because we had them up on the monitor on the wall.
Correct,
But
and that
they
was
were
fine.
saying, wow, that's not what I had heard later.
Did the team say that that was not what should have been done?
No.
We'll talk about this and make a plan.
So, and again, I mentioned that coronaries are pretty close to the aortic valve. And we'll be putting the valve, especially again the core valve, and sometimes it can happen with the Edwards valve too. This is the left main that comes from the aorta. This is aorta. This is the valve. Can you notice how pinched the ostium is?
No, you said good, yeah.
That happens, and that's what happened to few of our patients. And then what we do is put a stent, bring it over inside into the stent, the valve strut that keeps the ostium open.
So do you do that, do you see that at the time of you're putting the valve in, or does this happen a day later, chest pain and does it?
So that usually happens during the valve deployment.
So
It
you can
also
see
can
it
happen post-procedure too.
Okay.
This one actually, but we can actually determine if these patients are at a higher risk for coronary occlusion or not, and if we know that is what is going to happen to these patients, we kind of preemptively use radial access to get to the coronary.
That's when
We initially put in a wire to protect the coronary, and then deploy the valve, and then put a stent over it. So that's where your radial access comes into play.
So is that, we do those, how do you determine which patient population gets radial access from the start?
Is the CAT scan and the
That's
proximity?
we actually, yes, the coronary height,
Disease and.
coronary height
Okay.
from the aortic valve.
Okay,
If it is lower, especially women tend to have lower heights,
okay.
they get, and again,
How about people with disease in that artery, is that put them necessarily at more risk? I mean, unless it's
so
just
we
straight in there.
cath everybody. Now, we are cathing everyone, pre-procedure, like at least a month before the procedure. If they have coronary artery disease, significant coronary artery disease, and if we think that they don't tolerate pacing during the deployment, and actually do the procedure, you guys might have noticed there is a line saying that these patients get paced during deployment, especially with the core valve, I mean with the Edwards valve. And if that happens, if they have significant coronary artery disease, they may not tolerate the pacing. That's where we fix the coronaries first,
Okay,
before getting them to the TAVR.
okay.
But there are, and again, we can't do anything about the lower coronary ostia. And we only can predict these patients can get into a
Right.
complication.
Sure.
To prevent that, we use radial access and put a wire.
Okay.
So that's why it's rare. It doesn't, that you don't get that many patients with TR bands.
Right.
So, and again, so that it can again, usually it happens usually during the procedure, but it can happen post-procedure too. That's why watch for ST depressions, arrhythmias, EKG changes, and hemodynamic instability. And a few words about TR band.
So they come with the wire out always?
So we remove everything.
Because the risk is mostly at the time of the
Yeah.
placement, okay.
Yeah, we remove everything. We have to. We can't leave a guide wire in.
Okay,
But it's a risk of clot.
right.
So again, the TR band. When the patients come to you with TR band, check vital signs every 15 minutes as you would do anyway, and assess the site. Don't do blood pressures or venipunctures on that side. And again, I'm not sure what you guys do here. Are you guys getting? Do you get venipunctures on that side? Maybe not. And put them on the pillow, and instruct the patient to avoid bending their wrist. So in 2 hours after the application time, remove 5 cc's every 15 minutes until it's off. If that bleeds, put the air back in, and again wait another 15 minutes, do it again, repeat the steps.
So it sounded like M5 was really educated on these TR bands, so I think we just were setting up that would
Yeah.
get done.
Yes, that's
On the floor.
That's completely okay with
Okay.
me, especially again, the patients only stay there for 2 hours.
Right.
So that's the only thing that you guys have to make sure is like, if the TR band is, and I think this happened,
Handing
one
low.
of
Yeah.
hand
Sure.
gets purple, that's because of venostasis, and also they may notice tingling, numbness, pain and everything. So that's why you may have to let down to cc's of air, but before that, if you're not comfortable, call us.
Okay, good.
So, and again, what these patients can also have contrast-induced nephropathy, because we use almost around 100 to 200 cc's of contrast, or more than that, depending on if they have any vascular complication or any other complication. So they can get contrast-induced nephropathy. So that's why we make sure these patients get those bags that we order before they get to you. So confirm hydration, the CIN protocol, check their creatinine, electrolytes, watch for urine output, urine color, hematuria, and prevent hypertension. That can happen. And again, this happens too, unfortunately. So could be due to direct trauma or drug complication, hypothermia because of the fluids and resuscitation during the case, and just anesthesia, allergic reaction to the anesthetic drugs.
It seems like more and more you're doing them under sedation.
Yeah, that's why I was talking about the minimalist approach before. Yes, we are trying to get everywhere else. That's what they are doing. So general recovery of TAVR patient. Head to toe exam, view vitals, your CSF empties every 15 minutes for about 4 times, and then for every 30 minutes next 4 times. Neuro checks, telemetry, what you're looking for, or pauses, AV blocks, arrhythmias, and taser capture. Pauses, significant pause is more than 3 seconds in sinus rhythm, and more than 5 seconds in atrial fibrillation. And look for dyspnea, crackles, stridor. Stridor is also important, and I think one of you guys have had that patient with stridor. And hemoptysis. Keep them in bed rest. Keep their legs straight. If you need, elevate the bed to around 30 degrees. I know your instructions say 45 degrees. Yeah. And check their labs and ECG. Watch for bleed and bleeding pulses, distal pulses. Human axis, from the axis side. Hematoma in the axis side. Notify the physician if your blood pressure is low. Again, everything is in the order set.
Yeah.
Blood pressure is low, or your heart rate is high, respiratory rate is high, temperature is high, urine output is low, SATs, oxygen requirements, and arrhythmias. So, and again, TAVR is here to stay. There are some changes.
I did not tell her to say that.
Well, we knew that. It's the trend, right?
Exactly.
It's a life-saving procedure.
Yeah, and the changes are coming. Then again, we are doing this because that is better for the patients. It reduces hospital stay, better outcomes with the changes that are coming up. And I think we can make it better and successful by combined effort from everybody. And we appreciate you guys very much with the quality of care that you guys provide. And we're happy to, I'm happy to answer any questions. And again, if you cannot reach me, if that is my day, Mohammed El Haddad is the other physician, other fellow. I wanted to get his page number and I forgot, but. So, or you can call Cath Lab, depending on where we are. And again, it can be Cath Lab or OR, but.
Where do you see this going, the future? And
So-
how soon, time frame?
We will be seeing more and more intermediate risk patients. So that means more conscious sedation. No lines, and I already noticed that you guys are getting the IV team, or you guys doing this. So that means more blood draws by you, so there is no radial line.
Right.
And more transfemoral patients. That's what you guys know, and that is not going to change. So we're going to do hopefully no Foleys.
Really?
Soon?
But, well, maybe not soon, but that's Dr. Dowerman's hope. That's what they're doing.
Do you guys have, so a lot of times people have gotten a lot of fluid during the procedure, and they're gonna have to pee, meaning they're gonna have to, men are gonna have to move, or women are gonna have to get out of bed, and so are you guys all concerned for increased bleeding with that movement?
And again, there is that risk, but everybody is doing it.
Yeah.
So, especially in elderly patients with their BPH and prostate cancer risk, we're seeing, at least we have like few patients with bad hematuria and they needed Foley irrigation. So that's, which risk do you want to take? So again, we address this case by case basis, and low risk patients, and we think this is what is they need, we can put it in, but we are hoping to try avoid this in future. And you guys may get, and it's too soon though. Once our mitral program develops,
Right, yeah.
good, you may get those patients too. So.
How'd that patient do? How
So
did they do?
those
I haven't really
patients,
done.
we don't actually do any arterial access. It's only venous access. It's a bigger sheet, 23 inch. It's only one leg.
Okay.
It's at least two cases that we did so far seem to be doing okay. Less bleeding risk because it's venous bleed again.
Sure.
Can you stitch that? Can you stitch that closed?
We actually put percloses even to the vein. So, like what we do for artery, we do percloses for the vein. It's like 2 stitches. But that may or may not take. So that's what is coming now in the pipeline.
How are they using this in countries where there's socialized medicine? How is it different than what we're doing here?
In terms of,
Well, I lived in New Zealand for a little while, and procedures are quantified and given to those most in need. And some people wait
Right.
for a long time, and in the process,
Right.
in this case, they would pass.
right. So even here, we actually again determine how sick these patients are. If we notice that these patients are getting hospitalized, for example, if we have somebody who gets hospitalized within the last few weeks, that means we lost few patients because we waited for them to get better, or few things to clarify. So we didn't want that to happen. That's why we're bringing them sooner. If the patients are really sick, if they have orthopnea to the point they're not able to lie flat, we have to do this in a week. The procedure in a week.
In a week.
And that's how it is in socialized countries too. It all depends on how sick the patients are.
Mm.
So patients who can wait can wait. So, but we prefer to do it when they are in better health than when they are at the end stage. So it's
Right.
a morbidity and
Fine
mortality.
line.
You had mentioned some issue with, like the calcification and the difficulty getting the valve to adhere. Has that?
So, we have to have some calcium for that to anchor, but it also used to be a problem with leaks. But now with the skirt, the chance of leak is much less because that skirt actually, collects the blood. It won't
And
let
there's
it leak.
no risk of migration of the valve?
So I didn't want to talk about that just
Okay.
because it's you may not notice the valve migration, but we can usually on the procedure table itself. During the deployment, if there is a PVC, the valve can go up. So we have to make sure that doesn't happen. So we lost one patient actually with valve getting up because of a PVC, and it included both coronaries. So this valve is and she has so much calcium, it got stuck. We couldn't snare it. So it was almost 1 hour, we couldn't snare it, so we lost the patient. But the valve can embolize. With the newer core valves, we can actually recapture them.
I was
If
wondering.
if we think it's going to embolize, or if we think it's not in the right place, we can recapture and redeploy. So the technique again is changing. So it's getting better. Yeah.
So
And
before
more-
where we would see maybe you guys deploying 2 valves, will we not see that
When
as
this
much?
happen- Yeah, you may not see that.
Right.
Now it's decreasing, that is the
Yeah.
reason. And sometimes we actually go into the case thinking that we would deploy 2 valves in this patient.
Oh.
Because if we are doing this for more AI and bigger root, we have to put 2 valves. So one, if they have no calcium, 1 valve for anchoring purpose,
Oh.
and the other one goes in.
Oh,
So,
okay,
yeah,
gotcha.
so.
What do you think
It
about the
used to be-
quality of these valves versus the old standard way of open sternotomy? Is it the same quality?
So
Length?
we don't have much data more
Oh,
than
okay.
5 years. So 5 years data, they are comparable. So, if there is a problem, we can still put in a valve in valve, they will bring him back. So 5 years is good for these 85, 86-year-olds.
Yeah.
Sure, right.
And it used to be even the PCIs, not sure, this is what I heard from my physicians, even the PCIs, it used to be a big deal before, like, planning few days
Yeah.
prior, bring them one case per day,
Yeah.
anesthesia.
Yeah.
And now look at how we are doing
Yeah.
the PCIs. Just
And they go home same day.
Same day
Yeah.
discharges.
Right.
We are hoping the TAVR would be like that soon. Wow. That would be amazing, right?
Yeah. Now, my question, I've had a couple watchmen, and then they're like, oh, they're post-TAVR. Is that, did I just get lucky and get a couple of them with different histories, or?
Yeah.
Okay, so
Yes.
that really had nothing, it wasn't like a watchman was put in to collect, okay, all right, just
Watchman,
curious.
yeah, it's a totally different problem than, and again, watchman is for atrial fibrillation. These patients can have atrial fibrillation, they get watchman before or after.
Yeah, I just didn't know, because I was just curious, like, oh.
Yeah, again, depending on
Okay.
how lucky you are,
Yeah.
you get it. Pretty low risk patient or severely sick. Any questions, guys?
Overall, we've had good outcomes, right? I mean, for this program?
Yes,
like-
we lost what, 3 patients in the last 5 years.
Wow.
That's on the table. I'm not talking about post-procedure
Okay.
mortality, and we're actually
You have a
better
sense of
than
how-
lot of institutions. Our TAVR outcomes are very good.
Since they've been coming through the PACU, the ones that we've recovered and gone to the floor, we've had, see any of them come
It's
through?
actually, we are sending, the patients appreciate it when they go home a day sooner. That's amazing. Yes, we are seeing a lot, and that's why we are actually doing this.
Yeah, right.
Yeah, send them to PACU instead of putting them in SICU,
How many hours post-procedure are they up on their feet?
I usually say 6 hours, unless they have a complication.
Wow.
So like complication being bleeding issues or
Bleeding,
rhythm issues?
yeah. Oh, but like yesterday, for example, out of those 3 patients, one had hematoma, so I had to keep her on bed. The other one patient got up and walked already, and one more, who was there last, darling? I think, I'm not here.
Yeah.
I had to hold 1 hour of pressure, so I didn't want anything to happen, so I kept her on. Last 6
Yeah, just keep it alive, yeah.
Yeah, last 6. So
Awesome.
I hope this helps, guys. Yeah.